Hello, everyone. Welcome at the Acriva Trinova global webinar today. I hope you are going to enjoy the exciting program of this webinar. Ophthalmology, and in particular eye surgery, is an exciting specialization because there is a lot of new innovative products coming into the clinical practice, which helps us to serve our patients better and better. And trifocal lenses are one of the great examples of this surgery, and these specializations just moves ahead, because nowadays we are able to provide our cataract patients and refractive lens extraction patients with the procedure which enables them to live class-independent lives in their professional and personal lives. So I think that's really a great period of time. And today we have a webinar on one of the most innovative products, Acriva Trinova. And I would like to introduce to my co-speakers, which have great experience in the topic. And we will have Florian Kretz from Rhein in Germany, who is going to introduce us into this sinusoidal trifocal diffractive rod. Hello, Florian.
Hello, Pavel. Thank you very much for the invitation to join you.
I'm happy to have you here with us today. I would like to mention that Florian was cited as one of the 50 most influential ophthalmologists worldwide. So I think that's someone who really has this word on many topics, and definitely trifocal IOLs is one of the topics among them. Our next distinguished speaker is Naris Kitnarong from Thailand. Hello, Naris.
Hello.
So Naris is an associate professor of Sirirai Hospital of Mahidol University in Thailand, and he is well known in this country and beyond for these innovative approaches, and he has an extensive clinical experience in this sinusoidal trifocal IOL in his patients, and I'm happy Naris is going to share his experience.
Yes, good afternoon, everybody. It is my honor to be here and join this webinar.
Perfect. And we also are obliged to VSY biotechnology company, not only for developing this unique product, but also for organizing and sponsoring this webinar today. And let's have a look at the basic information about this innovative IOL. So that's the first and only sinusoidal trifocal IOL. And you will hear more in detail from Florian about the technical aspects of this unique optics. But I think we eye surgeons, when we hear about diffractive trifocal technology, we see the sharp steps on the optics, which to me was a great surprise when it came for the first time on the market. It looked to me like the old LP play record desk for the music, which was just miniaturized and which works on optical principles, but it provides absolutely great results, and trifocal lenses are the most frequent lenses in my practice, in my hands. I really like to use them, but VSY Biotechnology took this technical principle to another level. So now they have stepless sinusoidal technology, and they achieve trifocality with this technology, which is truly amazing. So here we see the surface profile of Acriva Trinova. That's a next generation trifocal IOL, and there are 12 unique ridges, but they are just seamless with no sharp edges. And that achieves an optimal light distribution throughout all distances. And Florian will tell us more about that, how these sinusoids just split the light into the two orders for intermediate and near vision. And I think this is really, really something innovative. So we have a few questions for you at the beginning. So then we know where we are and what's your daily routine in general. So the question number one is, what is the trifocal IOL rate in your cataract surgery? So please just pick up your answer. It's A, higher than 50%, B, between 30 to 50, C, between 10 to 30, D, less than 10, and E, I don't implant bifocal IOLs at all. So we need about 30 seconds to collect all your answers and process them. So please do hit the button as soon as you want, and we will then recognize the audience here today, and we will try to adapt our information to you to get to you the appropriate information about this trifocal technology. And I am curious about the results of this poll, because there are surgeons who are really in favor of trifocal lenses, and there are surgeons who are really afraid to use them because of certain reasons. So we'll see what's the population which joined the webinar today of our colleagues. So I hope we get close to be able to collect the results. So what do we expect? I think something 10 to 30% would be my guess, but we'll see. Maybe we have majority of people less than 10 or majority between 30 to 50. That's going to be a surprise, and that's good that we have the poll at the beginning, so all three speakers can adjust their information a little bit according to our audience today. Okay, so I was not far away, but we have 40%, 43% people here today, eye surgeons, which do not implant trifocal IOLs. And my guess, between 10 to 30, it's on the second. It's 25%, 1/4, then less than 10, and only about 10%, 11% between 30 to 50 and higher than 50. So that's a pretty nice split. And we will try to just adjust our information according to this all results. And I'm going to you one more question today for you, and that's question number 2. What is the main reason the ophthalmologists are not implanting trifocal IOLs? I think we need this question because majority of you here do not implant trifocal lenses. So A, high cost, B, risk of dysphotopsia, C, not having time to explain benefits to patient, and D, others. So high cost is certainly an obstacle for many of us and many of our patients, especially in certain parts of the world. Risk of dysphotopsia is widely known and associated with trifocal lenses, but here comes a great advantage of sinusoidal technology, which significantly lowers this risk. Definitely dealing with premium IOLs and trifocal IOLs in particular is just demanding for chair time, and we need to talk to our patients before and after the surgery, explaining the benefits, risks, and just to get them through sometimes a demanding period of neuroadaptation. And the others, I think there is a plethora of different reasons which might prevent eye surgeons for using this technology, including the long-term, the stability of trifocal lens, and just the differences in refraction and the need to fine-tune the ametropia. If we do not hit ametropia after the surgery, the patients cannot really benefit from the main advantages and become glass independent. So that also it is demanding for precise IOL calculation, and for it's also advisable to have just access to excimer laser or some other ways to correct the refractive errors and surprises. So we'll see what are the other reasons. So let's have a look at the results. Yeah, I didn't guess here, but I think that's the main reason why many of us or many surgeons are afraid to use trifocal lenses in general or in majority on everyone. So they select the patients carefully, or they do not implant the trifocal lenses, as 40% of the attendees today said at the first question. So risk of dysphotopsia. So I think that's again the topic for Florian to explain the optical principles, and then Naris will just get us through the clinical results, because we of course need to understand the technical and optical principles, why certain trifocal IOLs have lower dysphotopsia rate. But on the other side, we do need to confirm the theoretical information by clinical results. And that's how we physicians should work in clinical practice. Okay, so thank you for answering my two questions. That was, I believe, good to start with. And we will continue with my presentation. And I just have a few more slides for you to introduce the product and show you a video, and then my two co-speakers will continue. So this is the lens we are talking about, described at this slide. It's foldable, injectable, single piece, zero angulation lens design. It's made of combination of hydrophilic and hydrophobic acrylic copolymer, and the premium part of this lens is ultra definition aspheric optic, which is designed on this plate haptic with 11 millimeter overall diameter, and we usually in clinical practice deal with this lens through 2 millimeter incisions. It has all enhanced square edge around this plate haptic design, blue light filter, and it's manufactured in wide range of optical powers from 0 up to 32 in 0.5 dioptric steps or increments. But what I said earlier, the unique part is the sinusoidal optic, and the sinusoids result in very effective light transmission. So there is a 92% of light effective transmitted and only 8% of light loss, which is truly unique among trifocal IOLs. It provides a wide depth of focus, excellent MTF results, and also outstanding optical and visual outcomes in mesopic conditions, and it does minimize dysphotopsia. So dysphotopsia was the main reason why some of you said, I don't want to touch trifocal technology. So let's hear in quite a short time more about this problem. Meantime, I would like to share this video showing how we handled Acriva Trinova sinusoidal technology in clinical routine. So you see the lens in the package, and here I tried to visualize the sinusoidal 12 ridges on its optic under the operating microscope at our operating room. Take the lens out of the holder, place it into the cartridge along its longitudinal axis. There is OVD in the cartridge. We close the cartridge wings and push the lens through the cartridge in the injector. I like to use the band-assisted technique and inject the lens with no need to fill the eye with OVD. It's very easy to get the lens into the bag, but I stopped the video just again for the purpose of visualization of this unique optic, and it's easy to reach underneath of the optic if you need to aspirate the OVD in the lens self-center. And once again, I try to visualize the unique sinusoidal optic of this lens for you, just for the purpose of education. So that was a very short video which just shows how I deal with this lens in clinical routine. And there is a picture with retro illumination, and you see on the side of the picture the theoretical profile of this lens, and then we see how it looks like in retro illumination. So if you look a little bit more in detail, that's a different picture compared to the other trifocal diffractive technology. This lens is also available in toric versions, which is important because toric lenses are getting more popular worldwide, and astigmatism is quite common, and it's like 25% of our cataract patients have astigmatism over 1 diopter of cylinder. This lens provides excellent rotational stability, and it's possible to rotate it in both directions, clockwise and anti-clockwise, which is different to some of the competing lenses. And again, wide range of diopters, optical powers from 0 up to 32, and it's coupled with wide range of cylinders from 1 up to 10. So you can find virtually any combination for all your patients to correct their refractive error. So I just would like to thank you for your attention for this presentation. That was my presentation, and I would like to ask the next speaker, that's Florian Kretz, to get us in more detail into the technical world of this lens. Hello, Florian, it's all yours.
Thank you very much, Pavel, for the introduction, and thank you very much for this great product introduction of the Acriva. I'm going to talk a bit about the benefits of sinusoidal trifocal technology, especially compared to blazed diffractive trifocal technology, where I'm sure at the moment probably no one really knows what blazed diffractive trifocal technology means. Here are my financial disclosures. So today we speak a little bit about sinusoidal vision technology, and we divide it in commonly used diffractive technology and what it really means to talk about a sinus and why that sinus makes the Acriva Trinova so special. I think you already heard a little bit from Pavel, and I will try to explain it to you. I think most of you should be familiar with the Fresnel lenses. And the Fresnel lens in general is a syn-refractive lens. It's constructed by removing the non-refractive part of the lens, and it just reduces the amount of material required compared to a conventional lens by dividing the lens into a set of concentric annular sections. That's what we all know about the typical diffractive rings, and you can see on the figure in the top right how those diffractive rings create different focal points. And you can see that here, if you go in the schematic representation of diffraction of a parallel light beam by intraocular diffractive lenses with basic surface profiles. In picture A, you can see that on that first sharp bit, the lens is divided on 2 focal points. That's the typical Fresnel parabolic lens, blazed sawtooth diffraction. That's what we have in our renowned multifocals with 2 focal points. You can have the cosin step as a faceplate, which also divides it, but it changes the amount of light for each diffractive step. And then you have the sinusoidal faceplate, which basically gives you 3 focal points instead of just 2. And that in theory can go on depending on how you shape that sinus to have multiple focal points by dividing the light energy. But that's just the theory behind it. So if we look at renowned technology of diffractive lenses, you can see here each spark is basically 1 ring, and the combination of having different step heights makes the trifocality, because it's just 2 bifocal profiles combined, 1 for intermediate and 1 for near. And usually the intermediate one is half the add power of the near one. So some of the stray light is used and transferred to the near add point, which reduces the average loss of light from 22% to down to around 50, but I will show you that later. But you can see here Fine Vision, Artelisa 3, and Acristock IQ Panoptics with this typical profile of having a combination of 2 add powers. And that is how we create the 3 diffractive profiles. That's why it's called blazed diffraction, because it's 2 completely different profiles dividing light to one far point, one intermediate, and one near. And you can see that here how those points are combined and how those steps are created, but you also see that you need around double the amount of rings, because you always need one ring that gives you the near and one ring that gives you the intermediate. And each ring is going to create a halo. Otherwise, the principle wouldn't be working. If you look at the sinusoidal diffraction, it's a little bit different. You can see it's not a sharp edge, it's a round sinus. So the sinus basically gives you one distance, one intermediate, and one near. But here, the intermediate is the main focal point between distance and near. That also means there's less glare and halo because you only have half the amount of rings that you actually need. And you enhance the light utilization. And that is why the Acriva Trinova only has 8% of the loss of light. And those sinuses, they can be shaped like the diffractive rings. And with that shaping, you can change the energy distribution. For example, on the very right of this scheme, you can see with changing the shape, you can distribute more light to far, less to intermediate, and more to near. And this gives you great flexibility to optimize the use of light for your patients. Because especially in near, most devices we use have a backlight like the cell phone or the laptop. And this is why the Acriva Trinova, with less rings compared to all other trifocals, gives you a wide range of vision from far to near, with less dysphotopsia. Also, if you look at images of experimental results with a CCD camera, you can see that it truly has those 3 focal points, while the other lenses need more rings and more diffractive structures to create more focal points. You can see here the comparison of loss of light between the 3 typical used trifocal blaze diffractive lenses. I think you're all familiar, and you can see in average they have a loss of light between 14 to 15%, which is still good compared to typical bifocals, but still significantly higher than in an Acriva Trivial. Also, if you do some United States Air Force targets and you look at the range of vision, and especially at the pupil size, you can see the IOL B, IOL A, and IOL C really have a lack of intermediate vision under larger pupil size. And intermediate vision in dim light conditions is important by driving a car, for example, where the Acriva Trinova really has a benefit for that intermediate vision. But also the near vision is slightly better with a higher use of light energy under larger pupil sizes. So here I have one question regarding, the physical properties of the lens now. What comes to your mind when it is said glare and halo? A, just a circle around a light source. B, visual disturbance for only night drivers. C, not an important issue. D, an effect lowering retinal image quality. So I'm really looking forward to see the answer, because it can be quite tricky how you define the dysphotopsias and how you name it.
Okay, so now we need some time to gather your answers again. I think Florian has hit the target, because this question addresses your main concern, why perhaps not to use trifocal technology. That was the halo and glare as a side effect. So what does come in your mind when we talk about halo and glare? So is it only something around the light sources, or is it only something which just disturbs the drivers at night, or is it not an issue at all? Probably not the case. Or is it an effect which lowers the retinal image quality? So we'll see what is your opinion here. And of course, it is very important to address this issue. So the results are coming, and the majority of you at this moment are afraid about the visual disturbances only for night drivers. I think that's what is quite common in our daily routine, that we are afraid that trifocal technology gives problems to night drivers. That's absolutely correct. That's probably where our patients encounter some problems most common. But we have almost 1/3 of you thinks that this is an effect lowering retinal image quality. And now also 1/3 thinks it's just a circle around the light sources. So I think we have a pretty nice split. Hand it over to Florian to continue his presentation based on this poll results.
I do have to say, I think the definition of dysphotopsia is probably the problem and also the cause why so many people are afraid of dysphotopsia in their patients. And just one hint from my personal experience, we started using simulators for the patient pre-op, letting them show us how they see and how the dysphotopsia level is, because a significant amount of clear lens patients that are highly myopic or hyperopic, or especially cataract patients, already have a significant amount of dysphotopsia before the surgery, in most cases even more severe than after the implantation of a trifocal. But that's why we're coming back to the basis here. And you can see here photic phenomena. It's not that easy. In those lenses, we have a near, an intermediate, and a distance focus. And they all basically contribute to rings. And you can see that in the image. You have the center with the highest light intensity. That's the sharp point. That's the distance that they see the object in through that focus. And the rest basically just gives them some type of glare or some type of halo. The more distinct the circular is, the more it goes into the direction of a halo, because it's a distinct focal point. That's why they see a clear ring. If the light is further separated and widened because of spherical aberration of the cornea and stuff, that's when patients talk more about glare. So glare actually is a reduction of visual function with increased luminance, while the photopsia itself is simply the perception of a light flash. The prefix dysphotopsia in this case impairing visual acuity, because it's also something else the brain focuses on instead of the real focal point. The halo is just used to describe a blurred or dim circle around a light source perceived by patients surrounding the image of a bright spotlight, and actually comes from religion, where like Holy Ghost or Jesus had a halo around their head. But actually, all optical principles would not work if we would not have photic phenomena. Spherical aberration, for example, increases the depth of focus and increases the wideness of a halo. That's why it rather sounds as glare. Diffractive EDOF IOLs rather give like starbursts, while a good or best optical quality is achieved when the patient only sees a halo. So to consider that effect a little bit more, and we look at the FDA categories of dysphotopsia, with a point source of light that creates glare, a halo, or the so-called starburst. Multifocal IOL patients, they may experience a single bright halo, with those with diffractive EDOF IOLs, and tend to describe starbursts and fine concentric halos in a spiderweb pattern. But that is always, we have so many optical designs available. Actually, the optical design of the lens and the corneal aberrations explain you as a surgeon already which type of photic phenomena a patient can see. And if we look at light scattering forward to retina, it degrades image quality by creating a roughly uniform wheel over the true image. And the wheeling right reduces the contrast in the images, and it, if severe enough, can degrade visual performance. But you always have to think about that only happens if you have a really dark room and you only see that halo, and the halo becomes stronger than the actual focal point, which under real life conditions hardly ever happens, because especially those nighttime drivers, look at our displays now and compare your display 20 years ago to a Tesla. Now you have a disco light inside your car while you're driving, while before you actually did have true halo and glare. And in the cities, there's outside lighting too. So your pupil size does not extend 4 to 5 millimeters anymore at all. It rather stays an area around 3.5 to 4. So visual acuity and high contrast letters tested under photic condition is still the most common primary outcome measures used to assess visual performance after cataract or refractive surgery. And if we look here at the retinal image quality, it has been shown to correlate with the visual acuity task of lower contrast and lower luminance than the task of photic high contrast. But that is measurements that are actually not really related to our daily activities anymore. That is really some like special functions to try to analyze those photic phenomena. And if we come back and we bring those theoretical ideas, those theoretical testings now, and we think about an IOL that only has a loss of light of around 8%, and it doesn't have that many rings anymore, you also have less visual disturbances. You have a little bit of compromise in near and intermediate visual acuity for larger pupils because there's less rings available. But you also, the apodized design compromises near and intermediate light intensity in large pupils. And that is really where the Acriva Trinova's aspheric optic design and sinusoidal diffraction helps to create true intermediate and near vision with less risk for dysphotopsia. But honestly, I tell all my patients that they will have dysphotopsia. And if they wouldn't, then the whole system wouldn't work. And they need to understand it's like riding a bicycle. At first, you step on the bike and you have to think about every little step you take. But you get used to the levels of dysphotopsia. And to be honest, I have not explanted a trifocal lens or a diffractive EDOF lens in the last 6 years because of dysphotopsia. All those patients got used to it and they do drive at night. It's just they need to know what they have to look for. And most of my patients come back and say, oh, doctor, I do see those rings now. They're a little bit disturbing, especially in the beginning, but they're happy because they know the optical system works for them. Another very important part about optical designs is decentration or larger angle kappas, because a decentration or a large angle kappa actually is a non-true decentration, really like reduces the optical quality and increases the risk, especially for glare and starburst. Due to its design, sorry, and the larger central optical zone of the Acriva Trinova, there's less risk for true decentration and that the angle kappa does not go to the center of the IOL. The other benefit is that also because it has less rings and they are sinusoidal, the risk of dysphotopsia, the influence of it are quite lower compared to other trifocal lenses. So that is another benefit, especially if you're working in highly hyperopic or highly myopic cases, where you can have a deviation from the angle kappa, which can result in a decentration, not even dependent on toricity or anything else. The other thing, if you don't have a toric IOL, the capsular bag is not round, it's oval. Just rotate the lens and you will see that the second Purkinje image will be in the center at some point just by rotating the lens in the right axis, so the central optic is shifted onto the second Purkinje reflex. That technique works with nearly every IOL. You can see here one implantation of myself of a toric Trinova. I use the same technology or the same technique that Pavel has used. I just implanted under irrigation, and I especially liked it with toric lenses because you don't have any viscoelastic in the capsular bag, and you really know once the lens is positioned, it will stay there very stable. I don't polish the anterior capsule, so the anterior and posterior capsule can basically grow together and keep the lens in place. For me, I have very good results and very stable toric outcomes with that technology. So my take-home message is that the Acriva Trinova is a true sinusoidal trifocal IOL, and the design utilizes more light and gives less halo and glare. It works perfectly fine for our patients, especially distance and intermediate, give very great results. And it's a very comfortable vision also due to the blue light filter, especially in those cataract patients that with a clear lens, they often feel that the colors have changed. And I have to say, my patients are really satisfied with the outcome, and it's very stable for its toric component. So thank you very much for your kind attention, and feel free to contact me anytime if you have further questions that won't be answered in the QA session. And I'm handing over now to the next speaker.
Okay, Florian, thank you so much for your excellent presentation, and you took us on a really exciting journey into the world of the background of optics of this sinusoidal trifocal technology, which is really outstanding and innovative. So I think that was really important to see the different points and principles about the efficacy of this principle and about the advantages of really effectively using the light with low light loss and lowering the dysphotopsias especially. I truly enjoy that. Thank you very much. And you also point out an important aspect about this webinar, that the audience can ask us the questions just by writing them into the ask a question at your screen. So please do use this option if you have any question in mind, and we'll try to answer your questions at the end of this webinar. So we have the next speaker. It's Naris Kitnarong, and he will just present his clinical experience with Acriva Trinova IOL. Naris, go ahead, please.
Okay, good afternoon, everybody. So, where is my presentation? Give me a second.
No problem. Yeah.
So, a second.
So as I said earlier, it is important to verify the technical information which was described by Florian by the clinical results. And that's what Naris has done. And he has an extensive experience with this technology. I also presented some clinical results at the ESRS Congress, as was mentioned in Florian's presentation. And I think Florian has a wide experience also, so we'll be happy to share with you.
Okay, so thank you for inviting me to share my experience. So according to the world, I'm not surprised that just only about 50% of the audiences use the multifocal lens, I guess, because of some, some problems, something like that. It is the same as when I was just a young ophthalmologist, so I don't have the experience with the multifocal lens. But after I have been using multifocal lens for almost 15 years now, I thought that my duty is to purchase the ophthalmologist to use multifocal lens because of many reasons. Okay, you know what? Because now our world has been changing toward the aging society. This comes with the change of the diseases. For the ophthalmologist, we're gonna get more cataract patients. So this is a number of the cataract surgery that has been increased gradually. I mean, it's dramatically during the past few years. And what's come with the cataract surgery? Okay, so the cataract surgery nowadays is trending toward the refractive IOL technology because it's offer more options for the patients after the surgery to be maybe better comparing to in the past. So we have to fight with the presbyopia because the incidence of the presbyopia has been increased from 1.4 billion in the year to 2020, and it's expected to be increased to be 1.8 billion by the year 2050. That's why we have to try to learn how to use or get experience with the premium IOLs because it can improve the quality of life for the patients after the cataract surgery. The new lens technology has to be comparable with distance visual acuity with monofocal. But also, they must offer the better near vision without the reading glasses or glasses independence, and how to combat with the loss of accommodations. There are at least two ways to combat with that. The first one to restore the accommodation with the scleral approach, cornea approach. That's the most, effective nowadays is the lenticular approach. With the lenticular approach, we try to waiting for the accommodative lens, but it seems like the result is not as good as we expect as nowadays. The most effective nowadays is the pseudo accommodation with the multifocal lens. And so we, as Dr. Kretz has been explained about how the multifocal lens works, and we use two properties of the light that are reflective property and diffractive property. And with the refractive lens, IOLs, is some kind like we put many lenses into the IOLs, one IOLs, and it's produce the two focal point that is near and the distance, right? But so that's why we call not the real multifocal lens, is called bifocal lens. That's we have been using it. And with the diffractive design, is produce an interference grid. That's also produce the near and distance focal points too. So that's why I thought that we must call the old model of the multifocal lens as a bifocal lens. Why? Because it's produced the near and distance. Once the patient needs the intermediate vision, they have to get closer, like I have to do like this. And with the intermediates, it can be improved with the trifocal lens. And with the invention of the multifocal lens, the problems comes with the loss of the depth of focus and the loss of the contrast sensitivity. And one of the big problems that has shown from the poll is the problem the photic phenomenon include of the halos and glares. So how to be a success with the multifocal lens? This is my first part to persuade all of you to try to use the multifocal lens, because I thought that the big number of the patients with the multifocal lens are satisfied with the results, and sometimes they has never ever had the information about the multifocal lens, so they cannot choose the lens before the operation by themselves. The first one is you have to choose the right patient. How to choose this? Of course, the financial status is one of the important, because they have to pay by themselves. And after a while, I found that the financial status is not about how the patient choose the lens. They need to know the option, whether they have the choice of the monofocal lens, multifocal lens, trifocal, or something like that, even with the monovision. So once that the ophthalmologist gives them the pre-operative options, the patients will choose the right lens for themselves, okay? So we can consider about the socio-economic status of the patients, whether they're still active or not. The carrier, they have to use the near and distance or intermediate vision at the same time. The hobby, if they love to read, and one of the most important is the patients must have the good understanding and realistic about the post-operative outcome of the multifocal lens. One of the things that I really sure that you will see this kind of the patient is the motivation to be glass independent after the cataract surgery. And once you find that kind of the patients, you have to see if the patient has almost perfect eyes or not. That includes that the patients must have doesn't have any kinds of the ocular damage or concurrent ocular diseases. And if the patient has the corneal astigmatism more than one diopter, you might need to consider to use the toric multifocal lens. And because I'm the glaucoma specialist too, sometimes I put the multifocal lens in the patients with the glaucoma, but some patients with glaucoma after the cataract surgery, they will have the stable conditions such as ankle closure glaucoma. After the cataract surgery, sometimes they can stop using the medication. There is no increase of the intraocular pressure or they can be stable with the disease. Sometimes I consider to use this kind of the patients too. Okay, and the third step, you have to provide enough time for the pre-operative counseling, because you have to talk about the visual expectation, the understanding of the heroes and glare, and they need the time for the visual adaptation. And the question about, do we have to put the bilateral implantation? In the past, it is recommended to put the multifocal lens bilaterally within 1 month after the first operations. But in my experience, I thought that we can put the second lens in maybe different kind, even with the monofocal lens, or they can wait as much as they want. And the second, after you choose the right patients, you have to have the good biometry. Thus, you need the IOL master. Or if you don't have the IOL master, you need the immersion A scans. And you know what? The most important persons to calculate the IOL is the technician. So in my institute, we have the very good technician to check for the IOL calculation. And the last factor that is important is the surgeon factor. You have to choose the right patients, good counseling about the cost and the effectiveness, and also the side effects, everything before the surgery. And during the surgery, you need to do the small round CCC and intact porcelain capsule to be sure that the IOL is will be centration, will be in the good centration and very good stability. And if there is a little bit, or even with the mild capsular opacity, you have to do the capsulotomy. And the last one, you can consider to implant the same model bilaterally, or you can consider to use the mix and match in different presbyopic collection lens, because each lens has their own advantage. Okay, and even you can try to do one eye with a monofocal lens, or the other eye with a multifocal lens, or even with the monovision techniques. And because nowadays there are so many kind of the IOLs in the market, so you have to choose the right IOL for the right patients to match with the patient lifestyle. If the patient is the reading lover, you must focus on the near vision. And if the patient is the night driver, try to use the IOL with the less halos and glare during the nighttime. And for the computer user, or with the smartphone or the tablet, nowadays I thought it's era of the IT user. So the intermediate vision is very important for the computer user nowadays. If the patient is the outdoor or indoor activity, so you have to choose the right IOL for the right patients and the right patient lifestyles. Okay, and if you try to use the multifocal lens in the past for the bifocal lens, you have the +4 for the near vision, and I have the experience with the +4 for the reading very near. That is, you know what, for Thai people, we love to read very close. So the +4 is good. But one that they need to use the computer, you have to get very close. Or when they read the book, they have to bend over to the table. That is not smart enough for this era. Okay, so you can consider to try a +3.25 or +3 or +2.5, or even with a +1.5. But nowadays, more than 50% of my cases, I will consider to use a trifocal lens. Why? Because it is suitable for the condition nowadays that we using a computer, smartphone, a tablet, driving, and we have to see the map the same time that we drive, something like that. So nowadays, I keep using more and more with the trifocal lens. So I need to share my experience with the Acriva Trinova that I have been using this for almost 3 years now. That's because of some technical error with my institute. So I don't have this Acriva Trinova last year, but it's come back again. So this is a retrospective review of 17 eyes of 14 patients who underwent uneventful phaco with the Acriva Trinova implantation between December 2019 to March 2021 at my institute. That is a Faculty of Medicine, Silan Hospital, Mahidol University in Bangkok, Thailand. And this is all the results of my patients compared between pre-operative and post-operative visual acuity. So let's take a look. The average of the pre-operative visual acuity in LOGMA was 0.37, and it's turned to be 0.16 only on the first day after the operation. You can see that the visual acuity, even on the first day, is fantastic. This is a distance visual acuity, and it's improved to 0.09 on the first week. You know what? So for the distance visual acuity, everything is just fine. And for the last visits, the visual acuity remains 0.11. That is also good. And if we take a look for the near and intermediate visions, okay, so you can see that for the pre-operative visual acuity, it was 0.37, and it's turned to be 0.11 on the first week. And 76% of the eyes achieved the distance uncorrected visual acuity equal to 6 by 7.5 or better. And in these eyes, 76% achieved intermediate visual acuity equal to J2 or better. And for the near visual acuity, about 65% has a visual acuity equal to or better J2. This is a mean for about 4 months. But I have to tell you that in patients who has very good vision, so I will follow up the patient just every 2 or 3 times. That is on the first day after the operation, 1 week and 1 month. And just some patients come back to me after the operation about 2 years, maybe because of the decrease of the vision. So you can see that this is a distribution of the visual acuity. For the distance, everybody are happy. For the near vision, there were 2 patients with the posterior capsular opacity, PCO, and I have to do the YAG capsulotomy in these 2 patients. And after the YAG, they got the near vision back. And for the intermediate visions, 1 patient got the J1, and most of them got the J1 and J2. So that means that most of the patients got very good distant visual acuity, near visual acuity, and intermediate visual acuity too. This is the video of my patients that I did the operation last week, okay? Once I operate on the right eye first, and the next day the patient's very impressed with the results, and she asked me to do the second eyes on the next day. And this is 1 day after the operation. So I test the intermediate vision, and she got 25. Okay. I'm lucky that she can read the English. So you can see that she can read with the intermediate distance. And once that I test with the near vision. So she read in time. So and fantastic. She got 2025.
637
And as Dr. Kretz have shown in his presentation, you can see that there is a continuous of the vision. So once I move the reading card to the distance between near and intermediate, she keep reading at 20/30. And one of the things is that that's to ask the patient to read the letter one after the one letter. It's not the real practical thing. So you can see that she can read with the very fast speed, confidently. Okay, so this is I think that the result is very fantastic with the patients that I put the Acriva Trinova. So my conclusion is that most of the patients were happy with distance, intermediate, and near vision. Just only some patients who has the poor near vision, that's because of the opacity of the capsular bag. And once I did the ear capsulotomy, she got the near vision back. And in my patient, there is no complaint about the photic phenomenon at all during the follow-up, either 1 week, 1 month, or even the longest is 2 years. And in the case that has a poor visual acuity, in any case, the thing that we have to deal with it is a posterior capsular opacity that we can deal is easily with the ear capsulotomy. So in my experience with the Acriva Trinova, I thought it's acceptable with all range of the visual acuity. And because most of my patients are very old, so they may not complain with the driving during the night time. This is my reference, and thank you for your attention. Thank you, Dr. Pavel.
Thank you, Naris, a lot for sharing your clinical experience. I think that's really important, including mentioning some of the drawbacks of plate haptic technology like PCO rate, but you seem very enthusiastic about your patients and the results. So let's have a look at the questions from the audience. And the first question comes to Florian, and it's, did you experience less halo and glare with Acriva Trinova compared to some other trifocal lenses?
Thank you very much for the question, Pavel. Yes, we did. If we look at the outcomes for the Trinova compared to other trifocals, it especially has less distinct halo due to the less amount of rings. What you can see is that the glare amount is rather into an EDOF technology, but not as many halos. So we've used a summarizing formula for the intensity of dysphotopsia from Detlef Breyer. And also there we can see a pattern more likely than EDOF IOL, which is absolutely comparable from the intensity to pre-op values and not a typical trifocal blaze diffractive amount of halos.
Okay, thank you so much. That's important. And there is another technical question. Does decreasing the ring numbers like panoptics or apodization like fine vision in the lens design have significant clinical effect on the post-op outcomes? That's for you, Florian, I think also.
Yeah. The thing is that, yes, it does when the patients have large pupils. So in younger adults, for example, like females with a clear lens exchange that used to be hyperopic, that have a pupil size with really sometimes 5.5 millimeters, they have a significant decrease of near vision and intermediate vision under dim light conditions. As long as the pupil size is not too small, there's not really a problem because all the IOLs have central rings. I think here you rather have to highlight the larger optical center of the Trinova, that reduces the halo effect and the overblinding, especially during driving, and still opens patient when the pupil is playing from large to small, a constant good visual acuity, while the other lenses, vision can fade once the pupil becomes larger. And that effect can go very quickly if you drive from the city, for example, into the night, and your pupil enlarges, that then in the first moment you don't see your navigation properly. But there is a simple trick. You just turn on the backlight of the navigation and your pupil constricts a little bit more. So if you measure it, yes. For daily routine, I would rather say only sometimes there are other effects that have a greater impact for the Acriva Trinova technology.
Oh, thank you. That's an excellent answer covering all the aspects regarding the white pupils. There is one comment, not really an answer, that halo and glare due to the reduced amount of rings and sinusoidal technology is reduced, and the glare and halo is on the level of EDOF IOLs at our clinic, and the combined intensity was less than trifocal diffractive EDOF IOLs, but slightly more than monofocal EDOFs. So this is someone who says that this technology he places somewhere in between diffractive trifocal with sharp edges and EDOF. But I think in our hands, usually sinusoidal technology really provides reading ability, so that's significantly more than EDOF, correct?
Yeah.
Okay.
I do agree.
I think we are clear on that. And then there is one more question to Naris. So which IOL is your preferred trifocal IOL for your patient? And yeah, that's the basic of the question. Which?
So you know what? Because in my institute we have different kind of the IOL available nowadays. So as I mentioned, that we have to choose the right IOL for the right patients. Different kind of the IOLs has a different properties, such as for the Trinova, Acriva Trinova, is provides a +3, and for the intermediate is +1.5. So with the patients who has the lifestyle for the computer user, or with the mobile phone, something like that, it's good to use the Acriva Trinova because the range of the vision is good enough in that range. But in the patients who in Thailand, we always pray and put the book like this. So this kind of the patients, I will use a bifocal lens that is a +4 or more than +3, so they can read very close like this. So that means that normally I will analyze the lifestyle of the patients and choose the IOL to the right patients too. So Acriva Trinova is one of the model that I use regularly in my practice.
Okay, thank you so much, Naris. We have many other questions coming in, but unfortunately, due to the time restrictions, we will not be able to answer them. So unfortunately, I need to come to the conclusion of this webinar. I think that was really interesting. It's great. We have different trifocal IOLs at our disposal nowadays, and this is a very competitive field for high-tech IOL companies, and VSY is amongst them, and they really develop something unique. At this competitive field, there are also some lawsuits between the giants, and I think this was also in the background of this invention, and under the highest pressure, the best juice comes. And I think VSY have invented something which is truly innovative and great, with less light loss and still producing the 2 foci with one pattern, which can spread over the white pupil. So there is a great advantage, and I'm really happy to have it in my hands, and I can use this technology for our patients. So I would like to thank VSY team for developing this technology, for organizing this webinar, and I would like to thank both my co-speakers, Florian and Naris, for their excellent presentations. Thank you very much, and have a great time. Bye. Bye-bye.
Thank you. Bye-bye.
Bye. Bye.
Have a good day.
Bye-bye.